Hello students, you are welcome. This is your lecturer, Dr. Kojo Amiakosa. We are taking this time to go through Nurs 232, medical conditions of the integumentary, gastrointestinal, and endocrine systems. You know, these conditions as associated with these particular systems, we'll be looking at the brief overview of the systems, brief anatomy, and then some functions of the systems involved. But that will be brief, because in Nurs 231, which is the physical assessment, you've done almost all the assessment procedures, including subjective data collection, objective data collection, and confirmation of patients' conditions with investigative procedures. So in the first place, we are going to look at medical conditions of the integumentary system. So session 1, overview of the integumentary system. So this session overview, this session of the course will give you a general idea about the skin and its structure, as well as the major functions. And so you also be taken through health assessment to determine problems of the integumentary system based on the chief complaints of the patient. But as I've already informed you, for physical assessment, it's going to be brief because you have done them already. So what I'm going to do with you is just a brief discussion of the assessment procedures of the integumentary system. And then in addition, physical assessment of the skin will be taught using inspection and then palpation as a major technique for this particular assessment procedure. So as part of the integumentary system, inspection of hair and nails are also discussed, and then variations or the similarities in assessment findings of the older patients, for particular, as we grow, assessment techniques and then other manifestations also change. And so we may also be using this time to look at the terminologies used in skin lesions as we go through these slides. So at the end of the session, I expect that the students should be able to describe the structure of the skin and its functions, identify key variations, assessment findings for older adults, recognize different skin lesions, and then be able to carry out assessment on any patient with integumentary disorder. So the key topics to be covered in the session are as follows: anatomy and physiology review, and then the health assessment, and then skin lesions. Here we are not going to spend so much time because I hope that you have already done all these topics. So review of the anatomy. The skin, as you all know, as well as its glands, the hair and then the nail form the integumentary system. And this, the skin offers an outward covering or wrapper for the body, and that means to some extent it serves as a protective organ, and so it protects us from the exterior environment, and it's the biggest organ of the body and keeps the body from the outer environment. It also serves as a barricade or barrier to the loss of body fluids and then electrolytes. And then the skin also functions as a sense of organ for touch, pressure, pain, and then temperature regulations. Another function of the skin is that it serves as a reservoir for blood, so circulation in general. I want you to just go through this and then add other major functions of the skin. So you need to do further reading of the functions of the skin. So the structure of the skin, let us look at this picture. We have the major sections. We have the epidermis, which is the outermost part. We have the dermis, and then to some extent we also have the subcutaneous layer. And the dermis, as you can see from the screen, we have a lot of blood vessels, nerves, and then other structures. We can also see the basement membrane, and then within the dermis we have the sweat glands, and then the other major structures. So the dermis contains most of the nerves, blood vessels, and then sweat glands, and then major structures. And then on the epidermis, which is the outermost part, we see the sweat glands, the pores, and then we have the hair shaft, and then you can see the structure up there. The same structures are found on this particular diagram. So I want you to do further reading on glands of the skin, and then the hair and nail. Health assessment, as I've already told you, we are not going to spend so much time here. The basic things that we have to note is that, as we have already noted, the functions of the integumentary system. Health assessment, we need to do some kind of interview with the patients and then collect subjective data. So what I mean by subjective data is the data that you collect or you identify from the patient's perspective. It can be a patient, it can also be a client, and the physical assessment to collect objective data. Here, what I mean is that for objective data collection, our interest is to do physical assessment. So you as a nurse or any other person who is a health professional must be able to do a physical assessment in order to collect objective data from the nurses or the health professional or the provider's point of view. And these two, subjective data and then assessment objective, in terms of objective data, we combine the two to be able to reach at a conclusive decision in order to take proper care of the patient. So the patient history is the subjective aspect of the data, and then the objective assessment by the clinician is also the objective data from the provider's point of view. But another important thing is that as we are looking at the subjective data and the objective assessment, it is also very important in any clinical situation to do diagnostic investigations to confirm the patient history or the story from the patient, the assessment by the health provider. And then as we do this, then we are able to come out with a clear or true picture of the patient's problem. So subjective data plus objective data and diagnostic investigations are able to help to be able to diagnose in a meaningful way. So health assessment interview, there are so many things that can go on. And as I've already mentioned, there is part that the patient has to clear, and that part is the patient's story, complaints, and the physical assessment. For the skin, we have inspection and palpation as the major techniques. And as I've already informed you, you have done this. So you know what goes into inspection of the integumentary system. Here we inspect the skin, we also inspect the other sections like the hair and then the nails. So inspection is using the eye to inspect and then identify any abnormalities that the patient has. And then when we look at the palpation, here we use the palmar surfaces of the palm and then just do palpation to find out what is happening. And so the skin is assessed for color, the presence of lesions, temperature, texture, moisture, tegel, and the presence of edema. And then, as I've already mentioned, presence of lesions. Lesions can be of any type. So as we go forward, we have to remind ourselves about the type of lesions that are usually seen on the skin. So preparation, we need to get all the things done available for the assessment. So as we have already looked at, we have the inspection is one of the major techniques, and here we look for color, cyanosis, if the patient is anemic, or if there is pallor. These are seen with the decreased perfusion and the oxygenation, and then with cyanosis, which may be more visible in the mucous membranes and the nail beds of the client. In dark skin clients or patients, jaundice may be most apparent in the sclera of the eye. So we inspect the lesions. We also need to palpate for temperature and then palpate the skin for texture. And here the texture, in terms of palpation, we may be able to look for areas that are having lesions. And then the skin is normally soft and smooth with some roughened areas over the exposed areas, such as the elbow and then the buttocks and back of the neck. And then we also palpate for the moisture of the skin. And then as we do palpation, it may be important to identify from time to time degree of pain. For instance, if a patient has a heart condition which manifests probably with clinical manifestations on the skin, probably the patient has edema as a result of heart condition in terms of probably heart failure or kidney problems which may manifest on the skin with swelling, which may be specific edema. So we have degrees of edema: slight pitting edema, no obvious distortion, which is about 2 mm deep, is 1+. And then where we have 2+, maybe deep pit, no obvious distortion, which is about 4 mm. And then in assessment in NES 231, you have done all these things. So the measurement for to be able to identify 1+, 2+, 3+, and then 4+, you already know, whereby you use, you have to get a rule, and then you have to get a thread, and then to be able to measure the pit after palpation. And the inspection of the hair is very important. And then in some cases, excessive hair, as we can see in Cushing's syndrome. And then you can also see in some cases whereby we don't have hair at all, probably as a result of malnutrition, where we have kwashiorkor or any other condition. Sparse distribution of hair may be significant in the explanation of some kind of conditions. We can also have alopecia, which is hair loss, which may be related to radiotherapy, chemical or drug treatment. And these are all important during the assessment of the hair. And then palpate hair for texture, inspect the scalp for lesions, which is very, very important in most cases. And then the scalp, you know, under normal circumstances, we may have mild dandruff, which may be normal, but excessive greasy flakes indicate seborrhea. And then hair loss, pustules, and then scale appear on the scalp in tinea capitis, which is a scalp roundworm condition. And then red swelling pustules appear around the hair affected with other bacteria or fungi or other conditions. And then these are identified during inspection. And then you also need to look at the nail, and then look at the angles of the nail, and then see whether there are any abnormalities. For what we can see on the screen, we have the clubbing, and we know the clubbing, which may be associated with heart conditions, respiratory conditions, whereby the angle of the nail base is greater than 180 degrees. So clubbing, we have defined it, and then in most cases we don't have clear factors leading to clubbing, but it is noted that patients with heart and then some chronic respiratory conditions can have clubbing, in which the angle of the nail base is greater than 180 degrees and is seen, as I've already noted, in respiratory and then cardiovascular disorders. But we can't conclude because these are suspected cases. And then inspect the surface of the nail also to see whether there are any abnormalities. For instance, if there are swelling and the nail loosens in parenchyma, and then infection of the nail. And then, you know, people who do a lot of washing, especially at home without using machine, because they are exposed to water for several number of days, years, and then months, we also note that they can get this kind of infection, whereby either fungal or bacterial infection may be superimposed. Inspect the nail color. And the nail color is very important, whereby probably we want to find out whether the capillary return either slow or good. When it is slow, probably as identified in cases where the patient's HB level is low. But this may be difficult to identify in situations whereby we have candida infection, and then in dark people. And then you also need to look at the thickness of the nail. And in infection, like fungal infection, the nail becomes very hard, and then the trauma to the nail usually causes thickening. And then other causes of the thick nails include decreased peripheral vascular blood supply, and then thinning of the nails is also seen in nutritional deficiencies like kwashiorkor or marasmus. And then variations in assessment of older adults. Findings may be different, and so variety of skin changes may be apparent in the older people as we grow. As I've already informed you, we have loss of subcutaneous tissues, dermal thinning, and then decreased elasticity, which may cause wrinkles and then sagging of the skin. So this adult skin may be different from an adolescent whose skin may be saccharine because of the provision or the association with the important hormones in adolescent age. As we grow, the hormones go down, and so skin tegor and everything is decreased. And these are normal for the aged, and also dry skin, itchy skin in some cases. And then overall production of melanocytes decreases, while abnormal localized proliferations of melanocytes may also occur in specific areas in the elderly. And these are all things that you have to take into consideration when you are doing assessment of the elderly people. So skin lesions are very important, and skin lesions represent the most prominent characteristics of the dermatologic conditions, and they vary in size, shape, and then cause, and are classified according to their appearance in origin. We have primary and then the secondary. Depending on the stage of development, skin lesions are further divided according to type and then appearance. And so primary lesions are the initial lesions and are characteristics of the disease itself. Secondary lesions are affected by external factors, so result from external causes such as scratching, trauma, infection, changes are caused by the wound healing. So for instance, the primary lesion can change to a secondary lesion. Primary lesion, for instance, if we look at chickenpox, it's a primary lesion, but when it's itching and then there are a lot of external factors affecting it, for instance, scratching, then it will change to a secondary lesion as a result of the effects of the external factors. And so, as the name implies, secondary lesions are the changes that take place in primary lesions and then possibly modify their structure, shape, and other possible things that we need to take into consideration. So examples of primary lesions, we know already. We have macule, we have patch, and then we have papule, we have nodule, and then tumor. We have vesicles. Vesicles are examples of the lesions that we see in early chickenpox, and then small burn blisters, and then bulla, large vesicles or blister larger than 0.5 cm, and then large burn blisters and the contact dermatitis are examples of the bulla. We have pustule. Pustule is elevate pus-filled vesicles or bulla with circumscribed border. Size varies. You can get these ones in impetigo. We have carbuncles, and then we also have a cyst, which is an elevated encapsulated fluid filled and then semi-solid mass originating in the subcutaneous tissue. We have the whole. And then the secondary skin lesions, we have the fissure, which are the cracks in the skin, usually from the marked drying and then long-standing inflammation. They have sharp edges and then extending to the dermis, and then cracks are the corners of the mouth, as we can see in stomatitis. These are some of the secondary lesions. We have scales that can be shedding, and then examples that we can have is the dandruff and then the dry skin, and then we have the crust, dry blood serum or pus left on the skin. For instance, when accident occurs and people get some kind of abrasions and then cuts, bleeding can occur, and then when bleeding stops, some of them are settled on the affected area, and this become crust. It's very hard in some cases to remove them. So in most cases, when they are left for a very long time, pus can form beneath them, and then it's very difficult to remove. But with time, and then probably applying some fluid, for instance, normal saline to them, and then other fluids, it becomes softer, and then they can be removed. And then large crusts that adhere to the skin surface are called scabs. And here we have examples, as we can see, in impetigo, herpes, and then scabs following abrasion. Crusts are also seen in what we call them in situations whereby we have chickenpox, and at the same time can also occur and in situations whereby we have generalized eruptions, whereby somebody takes drug and then reacts to the drug, and we have generalized eruptions, and then scratching can take place. Lots of fluid exudates can be seen, and then left for some time. What happens is that they dry and they can form crust on the surface of the skin. We have atrophy, and then erosion. We have ulcers. Ulcers are very common, deep, irregular shaped areas of the skin, and then extending into the dermis or subsequent cutaneous tissue, and may bleed and may leave scar on the skin surface. We have scar, we have keloids. These are common ones, and then we have vascular skin lesions, and then vascular skin lesions. We have the purpura. I've given you the definition there. Later you can take your time and go through. And then we have hematoma. Hematoma is a very common vascular lesion. For instance, when there's a blow to any part of the body, blood may be accumulated beneath and then form a hematoma. For instance, if we do hernia repair, and then later on some blood can be collected in the scrotum and it can form a hematoma. So a raised, irregular shaped lesion that looks like swelling caused by leakage of blood into the skin and the subcutaneous tissue as a result of trauma or surgical incision may be termed as a hematoma, and we have a lot of them. When people fight, this can occur. When somebody has a blow on the face or any part of the blood can be collected, and then this can form a hematoma. At the initial stage, one of the interventions that we can use to treat a hematoma when it is formed, especially after surgery, is to apply cold compresses. For instance, if it's in the scrotum or any other part where we suspect hematoma being formed. And the idea is that when we apply cold compress, what happens is that it constricts the blood vessel, so blood supply or flow to that area is restricted, so that blood supply is limited in order to avoid accumulation. But whereby the hematoma is formed and then later we have infection also setting, we can apply cold compresses. So these are the two extremes that you need to take into consideration. We have the Petakey, we have also as part of the what we call it, skin assessment, we have shape and configuration. So once the type of the lesion is identified, the shape of the lesion and then the configuration of the lesion are noted. So shape may refer to the single lesion or the appearance of the multiple lesions, and then shape describes the contour of the lesion. Examples include round, oval, and then polygonal, many-sided, and then asymmetric. So we are talking about the lesions and then the type. So the shape defines how the structure of the lesion, and the configuration, how the lesions are arranged. So we have the configuration refer to the arrangements of the pattern of the lesion in relation to the other lesions. And so these groupings may be arranged either linear, following a line, annular, ring-like shape, confluent, merging, or run together, and then serpiginous, whereby we can see that the lesions have been arranged in the serpent-like structure. The following are other descriptions frequent employed under configuration. We have a secunate, which is circular, discoid, heptiform, generalized eruptions, which is a widespread, and then multiform. And then we have a reticulated, lace-like network structure. So we have these definitions, simple definitions, which later you can take your time and then go through. I know you have done these things, so just a revision for the first part. And then distribution and then demarcation. Distribution takes into consideration both the arrangements of the lesions over an area. And so distribution, we can think about localized distribution, we can think about the regional distribution, and then generalized. So localized, specific place, regional to a particular region, for instance, the trunk or the chest area or abdominal area, and the generalized from head to toe. Demarcation refers to the sharpness of the edge of the lesion, that is, whether it is discrete, isolated, or diffused. So we come to the end of the first session.